Okay, so we're back on track. Now you know why Dr. Warner's the king. I mean, he was there when Noah was growing the trees for the ark, if that gives you a clue. Anyhow, the next speaker is Dr. Shi, is going to talk about pathology. One of the things that Dr. Warner told you, and you're going to hear again, is that there are certain histologic tests that have to be done on neuroendocrine tumors so that we understand what it is that you have and can differentiate the good from the bad and the ugly. All right, so Dr. Shi is going to come up and talk about the NETS pathology.
Can everybody hear? Great. All right. Good morning, everyone. My name is Tanjuan Shi. I am a pathologist at Vanderbilt Medical Center in Nashville. So, as you know, I'm going to talk about pathology of neuroendocrine tumor. So, I will start with what. I don't know what's going on. Okay, what are neuroendocrine tumors? So neuroendocrine tumor originate from the neuroendocrine system, and the neuroendocrine system is composed of many different types of neuroendocrine cells that are diffusely distributed throughout the body. For example, there are neuroendocrine cells in the lungs, in the pancreas, and in the gut. So normal neuroendocrine cells in the different locations produce different types of hormone. Therefore, they have different functions depending on where they are located in the body. So I have a few examples here. For example, in the lung, the neuroendocrine cells can produce bioactive hormones, and these hormones regulate the airflow through the lungs. And some neuroendocrine cells in the gut can produce serotonin, and the serotonin can control the speed at which food is moved through the gut. And neuroendocrine cells in the pancreas produce insulin and glucagon. And the insulin glucagons are involved in the regulation of blood sugar level. So in addition, these specific hormones produced by different kind of neuroendocrine cells. And normal neuroendocrine cells in general can also produce two common molecules called chromogranin and synaptophysin. And basically most of neuroendocrine tumor cells can also produce these two hormones. Therefore, this chromogranin and synaptophysin are considered as a general neuroendocrine markers. So we use these markers to help us to make diagnosis in pathology. So as we know, all neuroendocrine cells can give rise neuroendocrine tumors. So the question is, are all neuroendocrine tumors the same? Actually, it's not really, as Dr. Warner already talked about. And neuroendocrine tumors arising from the different locations, from different neuroendocrine cells are different. They can be different in many ways, such as they have different genetic basis and they have different kind of clinical behavior. So they need to be treated differently. So in general, we kind of classify neuroendocrine tumors into three big groups based on their site of origin. I show you in this slide. Is point work? Cannot see well. So here I have foregut, mid-gut, and high-gut neuroendocrine tumor, three groups of. And in the foregut, neuroendocrine tumor, you can find the foregut neuroendocrine tumor in the lung and in the thymus. Thymus is a structure located behind the sternum. The pancreas and the proximal duodenum and the stomach. I think I missed stomach there. And the mid-gut neuroendocrine tumor can be found in the distal duodenum, proximal, distal duodenum and the jejunum ileum, and the appendix and the right colon. And the high gut neuroendocrine tumors, including those arising in the rest of the colon and the rectum. So, the lungs and the digestive system are the most common locations for neuroendocrine tumors. Approximately 25% of neuroendocrine tumors are found in the lungs, and 60% in the digestive system, including the pancreas and the gut. So this figure, I just kind of want to show you an idea of like how digestive neuroendocrine tumor distributed in the digestive system. So the rectum and the small bowel are the two most common sites for digestive neuroendocrine tumor, followed by pancreas and the stomach. So clinically, neuroendocrine tumors can be classified into two groups based on if they have an associated symptoms. So one is the functional tumors, and another one is non-functional tumor. A functional tumor can produce abundant amount of hormones that are normally produced by neuroendocrine cells they arise from. Because overproduction of the hormones can cause a hormone-related syndromes, so we call it functional neuroendocrine tumors. I think Dr. Warner already mentioned about a few of functional neuroendocrine tumors. I also give two examples here. For example, insulinoma is one type of pancreatic neuroendocrine tumor, produces excess amounts of insulin, and insulin can excess amount of insulin can cause low blood sugar. Gastrinoma can produce high amounts of gastrin. Gastrins can stimulate the acid production in the stomach. So therefore, it eventually may cause ulcer in the stomach and in the duodenum. So non-functional tumors do not produce hormones or do produce insufficient hormones. So there is no associated hormone-related syndrome. So, so what can pathology do about the neuroendocrine tumors? So of course, we can make a final definitive diagnosis. We make final decision. We can tell you if it is neuroendocrine tumor or other type of tumors. And we also grade the tumor, and we will tell you how the tumor will behave. And we stage the tumor too, and we want to let you know how extensive the tumor involvement is. However, pathologist has a very, very limited role in telling you where the tumor from if a person presented with a metastatic disease. As Dr. Warner mentioned earlier, all neuroendocrine tumors have very similar morphology. You cannot tell them apart. So what type of tissue we can use for pathology diagnosis? As most of the people you already know, we can either use biopsy to make diagnosis, or we can use resection specimen for diagnosis. So biopsy is achieved by removal of a small piece of tissue from the tumor. And the resection is done by removal of surgery by all or part of organ, tissue, or structure, including the tumor. So most of biopsy is done by a needle. So we call it needle biopsy. And so I have a picture shows you here, and this is a liver here. There's a mass in metastatic carcinoma tumor in the liver. So usually radiologists will locate the lesion and then inserts a needle into it, and then aspirate and get a small piece of tissue from that tumor. So that is a needle biopsy. There are two types of tissue can be obtained by needle biopsy. One type, this one on the left, is a core biopsy, and another one is the fine needle aspiration. Depends on what size of needle you use. If you use a large size needle, you will get a core biopsy, and a small size needle is for fine needle aspiration. So you can tell from these two pictures, core biopsy usually contain more tissue. And in addition to that, from the core biopsy, you can see how the tumor cells are organized. So actually that is helpful for pathology to make diagnosis, because sometimes how tumor cells organize can kind of give you idea. This could be a neuroendocrine tumor. So in addition to that, core biopsy, you get more tissue. We always make a tissue block for core biopsy. So you can like after you get this slides called H&E slides, and you can get more sections from the tissue block, and then you can do a number of tests. So, but for the fine needle aspiration, usually what you get is all these kind of dispersed tumor cells, tumor clusters. And sometimes probably you don't have enough cell for further test. So as pathologists, I like core biopsy better than fine needle biopsy. So what we can do on this biopsy, so of course we can make a diagnosis. For the core biopsy, sometimes we can also grade the tumor. So specimens, and I have two examples here, and I also show a small intestine neuroendocrine tumor here. So in this short segment of small intestine, you can see two tumors here. So this is also the small intestine is already opened. So the inner surface, this inner surface, mucosa surface of small bowel. And in this specimen, in addition to the small bowel, we also there is some fatty tissue attached to it. We call it mesenteric soft tissue. So when we get specimen, we always look for lymph nodes. All these lymph nodes hide in the fatty tissue. On this side, this is a partial pancreatectomy specimen for our pancreatic neuroendocrine tumors. So you see a mass here. We have ruler here. The mass is about like 3 centimeters in size. And this mass is surrounded by normal pancreas tissue. In addition to that, you also can see this black ink. And ink is used a lot in our pathology. And especially when the resection margin is very close to the tumor, ink will be very helpful, because grossly you cannot tell for sure if the tumor is at edge resection, but microscopically you will clearly see it. If the tumor is present on the ink area, that means there's still have some tumor left behind. So ink is really important for us. So when we get a specimen, the first thing we do is to closely examine the specimen. And we want to take all these measurements. We want to measure we want to measure the tumor size, how big is the tumor. And we want to measure how far away the tumor from the resection margin. And after that, after taking all these measurements, next step we take section. So we will take section not only tumor, we will also take section from the normal mucosa, and we also take section from the resection margin, make sure the tumor is completely excised. And in addition, we want to search for lymph nodes in the fatty tissue very, very carefully. Get as many lymph nodes as possible. Just want to make sure we can fully evaluate if there's any tumor cells in the lymph node. So that will be very important too. So here, actually, I show you tissue sections to the H&E slide. And this is actually tissue sections from a liver resection for metastatic carcinoid, well-differentiated neuroendocrine tumor. And you see there's kind of a whitish tan nodule. That is the tumor, and the background dark brown is the dark red colored tissue is normal liver. And after we get sections, we fix in formalin and then embedded in the paraffin block. And so then we cut a very, very thin sections from paraffin blocks, and then just mold it on slide and stain with HEMATOXYLIN and EOSIN stain. So the slides stain with HEMATOXYLIN EOSIN stain, usually we call it slides. You might already heard that. So what does a neuroendocrine tumor look like on H&E stained slides? So basically, HEMATOXYLIN stains the cell nucleus dark purple, and EOSIN stains the cytoplasm pink. So I take one example here. This dark purple is cell nucleus, and this pink background is the cytoplasm. So what are general pathology features for neuroendocrine tumors? There are two major features in neuroendocrine tumors. Number one is that neuroendocrine tumor cells are always uniform in size and shape. So I have one picture shown here. You look at this picture, this high power field, you can see that all the cells seem very, very similar. So that we always see it's very uniform. The second feature is neuroendocrine tumor cells has a very unique nuclei. We call it salt and pepper nuclei. Why? Because when you look at each individual nucleus, and you feel the nucleus is kind of composed of many very fine granules, like salt and pepper. So we call it salt-pepper nuclei. So, however, tumor cells among different neuroendocrine tumor, or even different areas of same neuroendocrine tumor, they can look differently sometimes. So I have 4 different examples shown here. The first one we will call it's ovoid kind of shape, and the second one looks like very rounded tumor cells, and the third one we call the plasmacytoid. Looks like plasma cells in the blood. And then the final one looks very spindle. We call it spindle cell type of morphology. So does tumor cell morphology matter? Actually, it does not matter because the tumor cell morphology cannot tell you where the tumor from. They cannot predict how aggressive tumor will be. So it does not matter. In addition, tumor cells can be arranged in different patterns. I have multiple examples here. The first one we call nests, basically composed all nests. The second pattern we call the trabecular pattern. And this one is rosettes. Looks like composed of all these rosettes kind of structure here. And cords, another trabecular pattern, and this last one is called a cystic pattern. So tumor patterns do not matter either. they will not tell you where the tumor from, will not tell you how the tumor will behave. So it does not matter. So usually we will not pay much attention on the tumor cell morphology or tumor patterns in our report. So how do we determine they are neuroendocrine tumors, not other tumors? Most of the time, actually, based on the two pathologic features I mentioned earlier, we can tell for sure that it's neuroendocrine tumors. But sometimes we use immunohistochemical stains to confirm. So what is immunohistochemical stains? I just show you a figure here. Just show you how the immunohistochemical stain is done. And for example, this is a molecule on a cell surface. And in the reaction, you will add an antibody called a primary antibody, which can recognize that molecule on the cell surface and then bind to the cell surface. And then after this reaction, you added another antibody called a secondary antibody. The secondary antibody can recognize the primary antibody and then bind to it. And in the second antibody, we also added some sort of enzyme type of reaction. And then you add all these reactive agents into the reaction. And then a reaction will produce a brown color. So when there's a molecule presented in a cell or on the cell surface, the reaction will produce a brown color. So brown means positive, means that cells have that molecule. So I have an example. This is a liver biopsy from a patient with a metastatic neuroendocrine tumor. So based on morphology, we kind of already sure this is a neuroendocrine tumor, but sometimes we want to confirm it. So we did a chromogranin synaptophysin stains on it, because as I mentioned before, these two markers are the general markers for the neuroendocrine tumors. And the vast majority of neuroendocrine tumors has these two molecules. So we can use this information to confirm the diagnosis. So you can say this actually is a background liver, normal liver, and this part is tumor. So background liver is negative for these two molecules, but a tumor is positive. So therefore, we confirm it is a neuroendocrine tumor. So the other thing is how much role of pathology can play on the telling you where the tumor from if a person presents with a metastatic tumor. But we do have a limited role for that, because first, every neuroendocrine tumors looks very similar, as I mentioned earlier. The second thing is there's not many markers for specific location of neuroendocrine tumors are now available. But sometimes we can try to help you, especially for the lung neuroendocrine tumors. Also, I think we still call lung carcinoma tumor, always express a molecule called TTF1. So we can do immunohistochemical stains for TTF1 molecule. So if it's positive, that means most likely the tumor is from the lung. So I have a liver biopsy again. That person presents with a liver metastatic disease, and we don't know exactly where the tumor from. So we can do a TTF1 to rule out or to confirm it's a lung primary. So here, actually, you see the brown color here. That means that tumor expressed TTF1. So we confirm it's from lung. On the other hand, most of neuroendocrine tumors from the digestive tract express a molecule called CDX2. CDX2 is marker for the intestinal differentiation. So we can use that marker to tell you if it's a digestive NETs or not. And this is another example of the liver biopsy for a neuroendocrine tumor. We have normal background liver here and a tumor here. And we did a CDX2, and we show it is positive. So therefore, this tumor is from the digestive gut. So that's all information I can tell you, but we cannot tell you exactly which portion of the digestive system. Basically, either small intestine or colon, they can all express this molecule. So that's all we can do about the location, differentiation of food location. So tumor grade and tumor stage are very important in predicting the outcome of neuroendocrine tumors. So in the next several slides, I will talk about tumor grade and tumor stage. So how do we grade neuroendocrine tumors? We are using WHO grading system. And in the digestive neuroendocrine tumors, WHO classified the tumors into 3 grades, grade 1, 2, and 3. Grade 1 tumors have mitotic rate of less than 2 per 10 high power fields, and Ki-67 equal less than 2%. And grade 2 tumors have mitosis ranging from 2 to 20, and Ki-67 less than from 3 to 20%. And grade 3 mitosis more than 20, and Ki-67 more than 20%. So in addition, in the WHO, it groups grade 1 tumor and 2 tumors into one big category. We call grade 1 and grade tumor as well-differentiated neuroendocrine tumor. But for the grade 3 tumor, it is called poorly differentiated or high-grade neuroendocrine tumor. So what is Ki-67? Ki-67 is a cellular marker for proliferation. It is strictly associated with cell proliferation. Basically, the high Ki-67 means high proliferation and probably faster tumor growth. And we also use immunohistochemical stain to detect Ki-67 molecule in the tumor cells that are proliferative. So Ki-67 proliferative rate is a percentage of Ki-67 positive tumor cells in total tumor cells. So I have 2 examples here. This bluish color means negative for Ki-67. And the brown color, I cannot point very accurately from here. But anyway, you see brown cells, stained brown is the positive for Ki-67 expression. In this picture, you can see only very few Ki-67 positive cells. The Ki-67 rate in this tumor is only about like 1% or even less than 1%. So therefore, this tumor is consistent with WHO grade 1 tumor. However, on this picture, you can see there are so many more Ki-67 positive cells. So the rate, Ki-67 percentage here is about like 15%. So this is a WHO grade 2 tumor. In the next slide, it is a poorly differentiated neuroendocrine carcinoma. You can see there are so many tumor cells, almost 100% of the tumor cells are positive for Ki-67. So therefore, it is a high-grade or poorly differentiated neuroendocrine carcinoma, and the tumor will behave very aggressively. So what is mitosis? Mitosis occurs when a cell duplicates into 2 genetically identical daughter cells. So I have one cell here. This is the nucleus. And nucleus contains genetic materials called chromosome. So when cells duplicate, they make 2 copies of chromosome and then separate it into the 2 copies. And eventually, each daughter cells get 1 identical copy of the chromosome. So that process is called mitosis. And we actually can appreciate mitosis on the HME slides. So I have an example of a high-grade neuroendocrine tumor here. So in this high-power field, I cannot see, but you can see the arrow in a picture. This arrow pointed to mitotic figures. So one of the mitosis here is just start separate 2 copy of chromosome. And another one here is kind of almost 2 cells formed. So that is mitosis. And mitosis, we always use mitosis, like Ki67, we always use mitosis to grade the tumor. So as we all know that tumor grades are very important in the prognosis. I have a picture shows here for mid and high grade neuroendocrine tumors. Basically, a person with, patients with a grade 1 tumor has much better prognosis than the grade 3 tumor. And in addition, tumor grades are also important in helping clinicians to make treatment options. For example, grade 3 carcinoma probably should be treated differently from grade 1 or 2 tumor. So how do we stage a tumor? We use AJCC staging systems. In the AJCC staging system, there are 2 types of stages. One is called TNM stage, and the second one is called anatomic stage. And TNM stage, including T stage, N stage, and M stage. T stage, also called tumor stage, designated for local tumor extension or tumor size. N stage designated for lymph node metastasis. If there is tumor in the lymph nodes, it is called N1. No tumor called N0. M stage is for distant metastasis. Positive call M1, negative for call M0. So TNM stage determines anatomic stage and classify anatomic stages into stage 1, 2, 3, and 4. The same TNM stage can determine different type of, if a patient presents same kind of TNM stage in certain location, they probably will call stage 2, and then others will call stage 1. But in general, the stage 3 tumor always have positive lymph nodes, and the stage 4 tumor with distant metastatic disease. So this diagram, I just want to show you how do we do T stage. So the small intestine has mucosa and submucosa, muscle and subselosa and selosa. T1 means tumor invades the mucosa and submucosa and less than 1 centimeter. And T2, when tumor size bigger than 1 or invaded the muscle. And T3 tumor means invaded through the muscle into the subselosa. And T4 means it's already penetrated through the entire wall. So that way, how do we T-stage the tumor? So again, stage is very important in prognosis as shown in this picture. So finally, I just want to give a sample of a surgical pathology report using small intestine neuroendocrine tumor as example. So we usually contain 2 portions in our diagnosis, and a top line and followed by a synoptic report. In the top line, we give you the specimen we received, what type of procedure is done, and the diagnosis, and sometimes we see multiple tumors, and tumor grade, tumor size, how deep tumor invasion is, and if there's positive lymph nodes or not, and if there's tumor is entirely resected or not. So we just give you all essential information in the top lines. And then in the synoptic report, we can give this essential information in a little bit more detail. In there, we also tell you what is mitotic rate, what is Ki67 index, and follow with all this information. We always provide you T stage, N stage, and M stage. So that is our diagnosis format. Usually we use during we sign out a case. So that's all. Thank you.